Hello, good evening everyone. Thank you for joining us tonight for our third and final session in our series, The Clinical Benefits of Multidisciplinary Team Care in Residential Aged Care Facilities. Tonight's topic is mental health initiatives. My name is Charles Broadfoot and I'm one of the Professional Development Officers with Hunter New England Central Coast Primary Health Network. I'd like to begin by acknowledging the First Peoples and traditional custodians of all the lands in which we are meeting on tonight. Pay my respects to elders past, present and emerging, and also welcome any Aboriginal people who may be joining us online. Tonight's session is being recorded and the recording and the PowerPoint slides will become available from tomorrow in our education library on our website. So to access these, you just head to our homepage, thephn.com.au, and click on the Education tab. Like all of our live stream sessions, we will be using Slido tonight for your questions and also the session evaluation survey. So on the right-hand side of your screen, if you're watching on a computer or laptop, you'll see the Slido polls and Q&A tabs. Alternatively, you can head to slido.com, so that's SLIDO, and enter our event code for this evening, which is AH3. So that stands for Allied Health and then the number 3. Or a third option is by scanning that QR code that has popped up on your screen. Please type your questions in throughout the session, but please know we have allocated time for a Q&A panel discussion to go through these questions with our speakers at the end of the webinar. It's now my pleasure to introduce tonight's facilitator, Dr. Marie Puxty, GP from West Armidale Medical Centre. Marie is the Chair of New England Division of General Practice, the Chair of Hunter New England Central Coast PHN Clinical Council, and Adjunct Associate Professor in the School of Rural Medicine for University of New England. She has special interests in medical education and psychiatry. So thanks again everyone for joining us tonight. I'll hand over to you now, Marie, to introduce the session and tonight's speakers.
Thanks very much, Charles, and welcome everybody. As Charles said, my name's Marie Puxty. I'm a GP in Armidale, New South Wales, and I'd like to welcome you all to the Hunter New England Central Coast Primary Health Network, third in a series of 3 live-streamed webinars outlining new COVID temporary Medicare items for allied health providers and GPs providing services to residential aged care facilities. These items are temporary, as far as I understand, till the 30th of June 2022. So the first in the series of webinars was about physical therapy in residential aged care facilities and the deconditioning effects of COVID. The second was about chronic disease management within residential aged care facilities. And then the third in the series tonight is about mental health initiatives for residential aged care facilities. During the evening, hopefully, we will outline the impact that COVID has had on mental health of many residents in residential aged care facilities, have an overview of the mental health conditions and eligibility of residents to access the various initiatives, a full explanation of the Better Access program for residents, including MBS item numbers, requirements, referral processes to psychologists, occupational therapists and social workers, and an overview of the benefits to residents of these additional therapies. So I'd like to now introduce our 2 speakers tonight, Wendy O'Meara and Julie Budgick-Smith. Wendy O'Meara is an Associate Education Consultant with LATA Consulting, as well as an RN and Practice Manager in Gisborne, Victoria. She has a long and diverse history in general practice spanning 20 years. She began as a practice nurse in general practice in 2000 before moving to her current role as Senior Operations Manager in a 20 GP general practice. And Dr. Julie Budgick-Smith is a registered psychologist who has worked in aged care for over a decade, both as a clinician and a researcher. She has significant experience in assessment and the application of psychological treatments to older adults. Julie has developed several preventative psychological group programs for older adults entering residential aged care, which won the Positive Living in Aged Care Awards. Julie is currently supervising mental health clinicians across several residential aged care facilities and delivers education and training to the aged care workforce. After our speakers, there will be an opportunity for question and answer. Please enter your questions on Slido, and I will do my best to try and moderate them, and we will all do our best to try and answer them. So thank you very much for attending. If it's okay, I'd like to now hand over to Wendy for our first presentation.
Thank you very much, Marie, and welcome everybody. Thanks for joining us tonight. As Marie said, tonight is the third of the series that we've been presenting on the new initiatives from the MBS. So I'd like to get started, if I may, when my presentation comes up. So thank you for joining us again. As Marie has very generously already covered the learning objectives for tonight, I won't go into too much detail, but as you can see, it's about recalling the impact of COVID-19 on the residents of aged care facilities, along with a description of the Better Access program and an outline of the new MBS item numbers that are available to both GPs and our mental health workers to assist residents living in aged care to access some additional services. So I'll get started. So just a bit of an overview, a bit of a reminder of where we're at the moment. So this is the current situation as of the 13th of November 2021, which shows the number of deaths we have experienced in the aged care sector as a direct result of COVID-19. So a total of 839 in Australia, with unfortunately Victoria way ahead of everyone else on 734, and New South Wales has currently 94. So it's a bit of an eye-opener to where we're at the moment. So statistic-wise, there have been 839 deaths in residential aged care as a direct result of COVID-19. And as I said, 734 in Victoria with 96 in New South Wales, and obviously the remainder spread out between the other states and territories. And New South Wales has currently to date experienced 278 cases in aged care facilities. So why now? Why are we where we're at now? Why has the government introduced this new initiative? So as you can see, it's a direct result of the Royal Commission inquiry into the quality and safety of aged care within Australia. This was instigated in 2018 by the Governor-General, Sir Peter Cosgrove, as a result of continuing allegations and concern raised about the quality of care that our elderly were receiving, both in aged care and in the community. And of course, during this time, COVID-19 hit, which obviously diverted the attention to the aged care sector in the emergency response and infection control. And as a result of this, the report that was tabled in March 2021 has put forward 148 wide-ranging recommendations for the fundamental reform of the aged care system. Obviously, I'm not going to go through all of them tonight, but I would like to touch on the three most relevant to tonight's presentation. So, Recommendation 3 states that the Australian Government should urgently create MBS item numbers to increase the provision of both allied health and mental health services to residents of aged care facilities who have been directly impacted by COVID-19. The other component of this recommendation is that any barriers, whether real or perceived, to allied health professionals entering aged care facilities should be removed unless genuinely justified. So this will prevent the locking out of GPs, allied health professionals, being able to enter and see those residents. So I think that's fantastic. Recommendation 61 is to create a new MBS schedule as of the 1st of November 2021 for all allied mental health practitioners providing services to aged care facilities. That includes psychologists, both clinical and registered, occupational therapists and social workers. This should cease in June 2024 when the aged care allied health funding arrangement is established. Just a bit of a word on that, so just so you understand what that is. It will come into effect in 2024, so this is the direction we're taking. And what it will ensure is that when a resident is assessed for care, that the actual assessment identifies appropriate health care for that individual to restore their health and physical and mental health to the highest level possible, but also ensure funding includes an amount to meet allied health care needs, whether episodic or ongoing. So this is a direction we're taking, and there's so much happening in the aged care sector in the future, so watch this space. Okay, so tonight's presentation is on the mental health initiative within this component. Basically, the impact of COVID-19 on the residents of aged care facilities and the aged care sector has been the greatest challenge they've ever faced, both with the significant impact of physical deconditioning for our elderly and the mental aspect of depression and anxiety. And let's not forget the correlation between the physical and mental health. So when you are feeling well physically, you're more likely to feel well mentally, and vice versa. So COVID-19 has certainly had an impact that just goes beyond, beyond belief. How has it affected our residents? Isolation, I think, is probably the biggest word to come from this. They have been isolated from their family, from other residents, from the workers in their facility, and providers. Also, the fear of contracting and dying from COVID-19 is very real for them due to their age and their comorbidities. And the fact that they have been quarantined in their room for extended periods of time, particularly early in the outbreaks. I do believe the first case in New South Wales, the residents were actually isolated or quarantined in a room for up to 6 weeks, which is a very long time to be removed from family and friends and social activities. But also the loss of social support and the risk of higher risk of illness due to their multiple comorbidities. So you can see why this has had such an impact on these beautiful people. Just a little bit of an overview on dementia. When we look at nursing homes, dementia is certainly something that comes up as one of the main factors, I guess. So just to have a look at this, it shows that of the 30,000 residents, of 230,000 residents, over 30% of them have a diagnosis of dementia as of this graph. And new entrant groups into aged care have shown, again, significantly high dementia rates in the 75 to 84 age group. So we're looking at nearly 50% of those. The other thing that's very important, and the thing I want to focus on tonight, is the correlation between both dementia and other comorbidities, so depression and mood disorders. All of these conditions that you can see are often experienced as well as dementia. So, and that's the focus I'd like for you to remember or to think about tonight. So what does the data tell us? That 49% of residential aged care facilities have been diagnosed with depression in the 2018-2019 period, compared with only 7% of males and 12% of females in the community. Now, as a general practice worker, we see mental health all day, every day. So it's when you look at that's only 12% of the community versus nearly 50% of the aged care sector, it's quite phenomenal. And 53% of residents were diagnosed with dementia. So of the 240,000 residents currently receiving care in our aged care facilities, over 50% have had a diagnosis of dementia. And as expected, these numbers will escalate as a direct result of the impact of COVID-19. So mental health in the elderly, it can be one of two. It can present itself in one of two ways, either as a transient or one-off episode, or as a chronic and recurring throughout one's life. Mental health conditions, in particular depression and anxiety, are highly prevalent in people over 65 years of age and are often dismissed as just a normal sign of aging. And it's very, very common to experience either depression or anxiety when you are transitioning, or when the resident is transitioning into the care of an aged care facility, which as general practice workers, we are all aware of. The most common mental health disorders in the elderly are listed there. I'm not going to read them all off. And as you can see, dementia is the top of the list. However, we're going to be focusing on more the anxiety adjustment disorder. And the reason I say that is because for the benefit or the purposes of this initiative, both dementia, delirium, and tobacco use are actually excluded as a mental health condition for the treatment of any service, for the provision of services. However, they can coexist with other disorders, hence the reason I introduced the slide which shows the number of patients with dementia who also have coexisting or comorbidities. So dementia on its own is not classed as a mental health condition for the purposes of this initiative. However, it can be it can be used in conjunction with other disorders, for example, depression or anxiety. The reason it's been excluded is in recognition that this condition does require specialist services, and delaying the referral to specialist services will only delay the treatment of the resident. So, as I said, dementia on its own is an exclusion. However, it can be used. You can consider it when you're looking at other comorbidities or other conditions. Just briefly, I talked on physical and mental health before. Just a very quick word on exercise because I think it's so important. Research or information tells us that light to moderate doses of and intensities of exercise have a significant impact on cognitive function in the elderly. The loss of socialisation and general mental health problems, along with decreased exercise, does give substantial negative impacts on these people. And although lockdowns are temporary, the actual effects are long-lasting and pose significant risk to the quality of people living in the population in coming years. So I do want to remind us that exercise is always something we should be considering for our elderly, hence the other component of the Allied Health Initiative that we've talked about in our last session. So, mental health, what is available? So, first of all, I'd like to give you an overview of what we currently have. So, the Better Access Initiative was introduced to general practice in 2006 with the goal to improve the treatment and management of mental health for those diagnosed with mental health disorders. The resident or the patient must have been referred under a mental health plan, and it was expanded in 2017 to include telehealth for rural and remote people, so as to enable better access, hence the word better access. What the Better Access program allows in the original format is access to 10 individual and 10 group sessions in one calendar year, so January to December. The service provision can be by clinical psychologists through psychological therapies, but also by registered psychologists and appropriately trained GPs, OTs, and social workers. It has now been expanded to include residents of aged care facilities, which is fantastic because prior to now, there was actually no Medicare mental health services available to these residents. So all I can say is it's about time. So from the 10th of, as Maureen mentioned earlier, they are temporary item numbers at this stage. So from the 10th of December 2020, which is nearly 12 months ago, to 30th of June 2022, which is only 6 months away, the expansion of the Better Access program has been made to include residents of aged care facilities impacted by COVID-19. The residents must be diagnosed with a mental health condition and can be many of those conditions we talked about before, but the most common is, as a direct result of COVID-19, is anxiety and depression. What it now allows these residents to access is up to 20 individual psychological services per calendar year, January to December again, with the flag fall being extended to cover these services. So now GPs and mental health workers who attend residential aged care facilities to provide these services are able to claim the flag fall fee, which GPs have had access to for several years now. It can be face-to-face or at your consulting rooms, so either face-to-face or the consulting rooms of your choice. And it's been extended, the telehealth component has now been extended to up to the 31st December 2021. The one thing I would like to say to all the GPs who are here tonight is please use this service because like most Medicare initiatives, if we don't use it, we will lose it. So, and there's no more eligible group than these residents. So please refer these residents that you have to this service to get it going and keep it going. So what does it require? It requires the development of a mental health plan by the resident's regular GP or treating psychiatrist. And the initial referral must state the number of sessions with a maximum of 6 for the first referral. So even though there are 20 services available, the initial referral can only refer for a maximum of 6. And the referral can be to, as I said before, clinical or registered psychologists and allied health mental health workers such as OTs, social workers, or GPs trained in focused psychological strategies. Before the additional services can be referred, a review must be conducted. So after the first 6 sessions, a review must be conducted and feedback must be received from the treating practitioner. After this, after which a referral for an additional 4 services can be generated. And then again, after that, so 6 services, then 4 services, and then the final referral for 10 sessions after those 4 services have been utilised. If there's, of course, at the time of review, a GP can claim the MBS item number 4, a mental health plan review, which then will initiate those further sessions. The referral requirements, it's very important that you include this information in your referrals GPs. So they must have the name, date of birth and address of the resident, plus a diagnosis along with the current list of medications. And as I just mentioned, the number of sessions being referred for. Referrals can be used across multiple years. So if you look at now, we're in November, if you were to generate a referral for one of your residents now and allocated the first 6 and they were then used, and then the additional 4 were used, but you didn't get to the additional 10, that can continue on into the next calendar year. However, there can only be a total of 20 services per year. So if you were to use 10 this year and 10 next year from the 1 initial referral, you could then only use an additional 10 to make up to the 20 for the whole of 2022. Hope that makes sense. It's very confusing. Other requirements, the service provision can be face-to-face, telehealth, telephone, or telephone, and it must satisfy privacy laws. So the resident must give consent. And I think an important part here for a lot of the mental health providers is that there is no requirement to bulk bill. So as a practitioner attending aged care facilities, the rebates are not excessive, they're not high, they're not attractive. So there is no incentive, there's no mandate, it's not mandated that you must bulk bill. However, you must provide the resident with informed financial consent. So they must be aware prior to commencing the treatment of any fees or charges that they may be liable for or may have to pay. So now we know the what, now we're going to look at the what, the how. What are the item numbers? So as most things with Medicare, there's lots of numbers and lots of descriptors. So what I've tried to do is break it down into different groups. So these are the item numbers that are available for general practitioners to create mental health plans. So as you can see, the item number all begins with the 93, which is our COVID item number sector. But the rebates mirror what's available in general practice. So it's based on time. So your preparation of a plan with either 20 to 40 or 40 plus, and then either skilled or unskilled. So exactly the same as we currently have in general practice, just different item numbers. This cheat sheet will be available, as Charles said, via the PHN tomorrow if you'd like to use this as a guide to what you can and can't use. And I'm also happy to answer any questions related to this at the end of the session. And down the bottom, you'll see the review of the mental health plan. Again, the item numbers mirror what's available in general practice. Then we have item numbers for focused psychological strategies, again, provided by either GPs or other trained health professionals. And again, these item numbers are additional. The first column is what's available at the moment, and the second one is what's available through either video or phone consultation. And again, the rebates are provided. So any GPs who conduct these FPS strategies or FPS program will be familiar with the item numbers, but this is basically just for information. Then we look at what's available for clinical psychologists. Again, a plethora of item numbers, all based on time spent, and whether it's initial or additional. So the initial, obviously, services will generate a higher rebate than the additional services. And yes, the flag fall is only available to face-to-face consultation. So if you were to do a video or telehealth or telephone consultation with one of the residents, you cannot claim the flag fall fee because you have not attended the facility where the resident is located. And then, of course, we have registered psychologists whose rebate is a little bit less than the clinical psychologists, but again, it's quite generous. Having said that, again, the option to privately charge on top of what you're being provided from Medicare will make it hopefully more attractive for service providers to attend these facilities. And then, of course, the OTs, their item numbers obviously are less rebate, not recognised as to the extent that psychology services are, but still quite attractive if you were to be able to claim the private fee, and also the fact that you're able to claim up to 20 services. So hopefully, but we need to remember why we're doing this. It's all about the mental health of these lovely aged care residents who need our help, or need us to put services in place for them so that they can regain their independence and regain some sense of normality. And of course, social workers also have a range of item numbers to use in these services. So the flag fall fee, just a brief summary. Of course, you have GPs use the 90001, which you can use when you attend your aged care facility for your consultations. It's now been extended for the preparation of a mental health plan. And then you have your OMPs, which are other medical practitioners. And of course, the allied health now have their very own flag fall fee, which generates a rebate of $40. And as the descriptor says, it can only be claimed for the first resident. So if a allied health mental health worker is attending a facility to see 5 residents, they can only claim the flag fall fee for the first resident, and then the others will just be the standard item numbers. So I hope that makes sense. There is lots of numbers there, so please let me know if there's any questions you have regarding that. So the MBS requirements for the mental health providers, they must be registered with Medicare. There must be a mental health plan in place for the resident that you are seeing, and the previous sessions, all previous sessions must have been used. So if there's been initial referral for 6 and then 4, they must have been used before the additional 10 services take effect. And the resident who is an aged care facility resident must not be admitted to hospital at the time the services are provided. So that's basically the only criteria that Medicare have set out. I do want to touch, we're very lucky to have Julie talking to us tonight as a psychologist, but I do want to also touch on very briefly on the role of OT within the aged care facilities. So occupational therapy assists adults who are experiencing psychological or emotional difficulties, just as do psychologists, but they help in different ways. So they develop better ways for the resident to deal with the mental illness in the context of day-to-day activities and managing their emotional problems. They work with other health professionals, such as psychiatrists and psychologists and social workers, but they provide an additional service. They provide emotional and psychological support, but they provide engagement in activities and building relationships with consideration of the person's culture and interests. So they try to make the services they provide relevant to what is actually causing their behaviour in the first place. And they also are able to find additional therapies or additional stimulation, such things as music therapy or environment adaptation. So please, let's not overlook the OTs when we're looking at the provision of services to residents, because they can actually work quite well with the psychologist. So, and I'm sure Julia will have something positive to say about that as well. But I just wanted to remind you of the OT option. The other thing that's available to us, which is not very well known, and I did want to touch on this briefly, is the DVA treatment cycles. So this has been around for a couple of years now. It was introduced in October 2019. And what it does is allow residents in aged care facilities who are gold card holders access to what's called a treatment cycle. There are unlimited treatment cycles, but one treatment cycle equates to either 12 visits or 12 months, whichever comes first. And psychologists and OTs are part of the service provision for treatment cycles. So if you were to use all of your Medicare item numbers, you can now also access this component to provide additional services to your residents with gold cards. And there can be as many treatment cycles going at once as you'd like. So you can be referring to a psychologist and an OT and a dietitian and a physio and a podiatrist, and all of those services can be running with each provider, with each additional provider providing one treatment cycle. So one resident can have multiple treatment cycles. There is lots of information available about this, and I am very mindful of the time that we have tonight, but I'd be very happy to answer any questions about this. or provide you with a fact sheet that you can look into it more. But please be aware of it if you're not, and if you aren't aware of it, please look into it, because it's an additional service, particularly for, well, only for gold card holders, as I said. So as the treatment cycle, part of the treatment cycle is that the provider must create a patient care plan. So when the service provider sees the resident for the first time, they create a care plan, which is then provided back to the referring GP. And at the end of the 12-cycle care, they must provide a completion report. And as I said before, residents in aged care facilities are eligible. It was previously only available to low-level care, but it's now been extended to both high and low-level care. And as I said also before, the mental health OTs, psychology and social workers are all listed as service providers for the treatment cycle. So something else to remember if you have a resident that you'd like to engage further in mental health help and support. And finally, case conferencing for allied health workers. So as of the 1st of November 2021, there have been an additional 3 item numbers scheduled in the MBS to allow allied health workers to participate in case conferencing. Now, yes, allied health workers have previously participated in case conferencing at their own expense because there's been no rebate available to them. Now, however, it's been recognised the important position, important role they play in the treatment of residents, or the care planning of residents. So the MBS has been extended to include provision of services for them. The case conference must be instigated by a GP, but it can be at a recommendation of an allied health provider. So a mental health OT may decide that they'd like to have a case conference with the treating GP and the psychiatrist or the exercise physiologist that's looking after that resident. So therefore they can feed that back to the GP, but it must be instigated by the GP. And the existing relationship rule has been removed for the provision of this service. So in recognition that often the case conference is usually based around a resident or a patient that the allied health workers don't know yet, and they're looking at how they're going to plan the care for these people. So they have removed the existing relationship rule, which means that you don't actually have to have met the person or the resident prior to commencing treatment and prior to having a case conference with the other practitioners. Again, the same as our everyday case conferencing rules, they are limited to every 3 months, and there must be 2 additional providers who cannot be family. Family are very welcome to attend and should be in attendance, but they are not qualified. They're not classed as an additional provider. So it must be 2 other providers providing additional services to the resident, and usually separate services. But they can be done via telephone or telehealth. So that's also something to consider. So that's fantastic news. And just a little bit of a snapshot. The MBS wording is, as we all know, always lots and lots of words, but I've given you the short version. Basically, it works exactly the same as general practice case conferencing. 3 levels, less than 20, above 20, but less than 40 and above 40. And there you see the actual item numbers and the rebates available for allied health workers to provide their services. So if you're not aware of it, please get engaged with it, because it's going to change the way we provide service to these lovely people. Okay, now I'm going to briefly just look at what role each of us play in ensuring that this program actually gets off the ground and gets working. GPs are by far the most critical role players in this, because if you don't refer these residents for the services, nothing's going to happen. So GPs are pivotal in making sure this program works. GPs are essential for diagnosing the mental illness of the resident, or psychiatrist is also important, but to ensure that the symptoms of cognitive decline, dementia or delirium, are not mistaken for mental illness. So as I said, GP's diagnosis is vital in instigating the appropriate level of care for the residents. And of course, GPs ensure that medications needs are considered as well. Many residents require medication or medication treatment as well as allied health providers. So the actual services do need to be co-aligned with medication. So GPs are pivotal in that. So what are the incentives as a GP to provide care to residents of aged care facilities? when I asked my GPs that, the one thing that all said was the rewarding experience. So my GPs have been in the area for over 40 years. So they have seen they are looking after many residents now that they have seen over the last 40 years and provided ongoing care. So it's very important to them that they continue to provide that service while they're in the facilities. The other incentive is that it gives the opportunity to ensure you can initiate appropriate services for your residents to optimise their quality of life. So as a treating GP, you know your residents, you know what would be beneficial for them. So it puts you in a unique position to be able to ensure that they access the services that they are available to them. Of course, the other incentive to this is the increased financial incentives. So obviously the flag 4 being extended, but I think probably the most significant increase to aged care is the aged care access incentive. So previously, this payment was a $5,000 total capped fee that was available to GPs who provided a certain number of services to residents of aged care facilities. The practitioner must work at a practice that is registered for PIP, for Practice Incentive Payment. But as you can see now, it is a tier-based approach. So previously it was based on 2 tiers. Now it's based on 4 tiers, but there's quite a significant jump. So initial services from 60 to 99 will provide a practitioner with a payment of $2,000. And then as you can see, the tiers step up depending on the number of services that are provided, up to a total of 180 or more, which then realise the last payment of $3,000. So this equates to $10,000. So basically, the aged care access incentive has been doubled for GPs as an incentive to prioritise or to provide care to residents of aged care facilities. And as the word says, they are services, not visits. So you could attend your resident and provide 3 services, which will go towards the total to meet the targets that have been set. So that's some great news for GPs. So GPs, what can we do? We need to recommence or continue regular reviews of our residents, get some treatment, diagnosis, review your residents, see what services you think would be beneficial for them, and start that referral processes. Add clinical reminders in your software to remind you when these plans are due for review, whether it be a mental health plan, or whether it be a team care arrangement or contribution to the aged care facilities care plan. Put those things in place so that you are reminded that you need to go and review the care plan and refer for further services. Otherwise, the time disappears and the services don't get accessed. Engage with other providers to ensure optimum care. So have those case conferences with other professionals to work out what's best for the residents, particularly psychiatrists or geriatricians. They become invaluable when we're looking at the aged care sector. And schedule in advance regular reviews for your residents to ensure that you have the adequate time you need to see them. As we all know, aged care provision takes a long time, or the services take a long time, and ensuring we have the reminders in place will help us to ensure that we continue to provide the services. So aged care facilities, again, GPs can't do this alone. The aged care facility needs to work collaboratively with the GP to ensure that the services that are required for the resident are initiated. So GPs rely very heavily on the aged care sector or facility updating them with what's going on with their resident, handing over to them when the resident's behaviour changes or whether their medication needs changing. So that relationship is vital to the ongoing provision of services for these residents. So make sure that the GP has access to the patient's file to review what they've been doing since they were last there, making sure you communicate any changes of behaviour to the GP, who can then review the resident and perhaps refer for appropriate services, and making sure that the information the GP needs is available, for example, care plans, diagnostic imaging. And another important thing, which is always not available, is the discharge summary, particularly if they've had an admission to hospital. Making sure staff are available when the GP attends to assist the GP with the residents, so handing over to them, discussing their behaviour, their moods, so the GP knows where they're at with the resident. My GP's biggest complaint when they attend the facility is trying to find someone who knows the resident, who can hand over to them what the resident's been up to over the past week since I last saw them. But also, if we're going to use IT systems such as telehealth model, to make sure someone is able to assist the GP or the resident to use it, because the elderly aren't very IT savvy. So if we're relying on a digital platform to provide services, someone needs to be able to assist the resident to access it. And of course, recruiting service providers. We know that, as we talked about earlier, the direction for mental health services or allied health services is going to become part of the funding in 2024. So it's about engaging and recruiting service providers now, so that when that time comes, we have the provision of those services. Retaining what you already have is important as well. And also involving the family in the planning of the resident's care. The family knows the resident better than anyone, so they're more likely to assist you to plan what's best for their mum or their dad or their brother or their sister. And having regular meetings with the visiting GP. So our practice once a month invites the aged care facility DON or the nurses to attend, and we discuss anything that's relevant at that moment. So there may be issues we're having, or the RACF may be having issues with something that's going on that we're not aware of. So we like to get them all together and have a chat about what's going on and work together to iron out any wrinkles that are happening as a result of that. And finally, the mental health practitioner, obviously the most important role play in this initiative. They enable people to function socially. They enable residents to function socially and emotionally. They provide a diverse range of interventions which will assist them to move forward and to regain their independence post-COVID-19. But they also allow the prevention and slow the progression of certain conditions, but they empower elderly to live full and active lives. So they are such a key role in the provision of care for these residents. Again, allied health service providers need to be able to access the care plans of the residents, particularly the mental health workers when they're coming to see the resident for the first time. And they also should be scheduling routine visits and having regular discussions with the aged care facility to see what, is the services we're providing suitable? Can we be of any more assistance? What else can we do? And creating care plans helping the RACF to create care plans that are relevant to your residents or to the people you're treating, including things like diet, exercise, and other therapies to help them. So, this is the fact sheet link. So the ones that this covers the whole 3 series of webinars that we've presented. So it gives you a link to all of the 3 important fact sheets that the government has provided. They are quite lengthy. I think they're about 15 to 17 pages each, but they are definitely worth reading if you'd like to get more information on the services. But ladies and gentlemen, in a nutshell, the impact that COVID-19 has had on the elderly residents living within the aged care sector has been devastating. And only through the provision of collaborative, person-focused care can we address the impact that it's had on these residents, both physically and mentally, with the aim of improving the quality of life that many of these residents who are living in the aged care sector they should be eligible for. So as I said, please refer for these services, because the MBS task force will review them and they will say, okay, they're not being used, we're going to remove them. So please refer. So I'd love to hand over to Julie now, who's a psychologist working in aged care facility, for her to give us some information, some valuable information on how we're going to, or how she sees this working for her. So welcome, Julie. Thank you.
Thank you so much. I really appreciate it. I'll just see if my slides can be brought up so that I can, yes, excellent. Okay, today's presentation is very timely because I've spent half a day in an aged care facility, and it was great. The referring GP was there, and the facility manager was there, and the key staff were there, and the key residents that I needed to see were there. And it just highlights what we've discussed so far about the importance of being able to work collaboratively to improve these outcomes. I'm not going to improve outcomes of an older person by sitting with them in their room alone and not engaging them in the environment and helping them mix with other residents and better adapt to their situation. So what we're going to do in my presentation, following Wendy's amazing overview of the services and all the billings available, is just to cover briefly about the statistics, what we know about mental illnesses in residential aged care facilities, pulling apart comorbidities, because that's one of the big barriers that I've noticed in particular, like how we, pull apart, is it mental health or is it declining physical health, or is it a neurological condition like dementia? How we escalate well-being concerns, and when do GPs actually find out, that a resident's mental health is declining? Is that shared in a consult with a GP, or does it come externally, or does it come from the family? We'll talk about what works with older adults. I'll introduce you to Jim and Elaine, and then I'll also, if time permits, also talk to you a bit about my research into emotional and psychological well-being in the workforce, which was part of my PhD. So there's quite a lot to cover, and I'll do my best to get through it all. So my introduction was done before. I worked in aged care for over a decade, and it has been challenging, even before these COVID items were rolled out, in terms of how are services actually funded. And I've always found that my passion and interest for this population always somehow found the ways to generate income, but it certainly has not been without the challenges, and not having Medicare items, or just relying on chronic disease plans, EPCs, and the likes. So I wrote a book about improving mental well-being in residential aged care, because it's been such a massive passion of mine, and it's called Beyond the Reluctant Move, and it talks about what it is, once people move into aged care. Move is often not something that people look forward to, and how do we help them beyond that stage? So it's been very insightful over the last decade, looking at, visiting all the facilities that I've visited in the Hunter region and in Sydney, and just hearing people's stories as to what has brought them to that environment, and what we can do to enhance their well-being, more so, in a sense of group programs, group interventions, and incentives to get them out of their rooms. So I'll just briefly introduce you to Jim and Elaine, who moved into an aged care facility after their son went on holidays. He didn't tell them that the plan was for them to stay there permanently. He said that he was going on holidays, and that once he returned, that they would go back home. But it wasn't discussed that they would be staying there permanently. So they were on this false pretension that they were only there briefly. And the news were not brought to them softly, gently. It was kind of blunt. Your GP said you have to stay there, and it wasn't actually GP who said that. It was the son's decision to move the family. His parents had to care. So Jim he's got a history of depression, which was never treated, but he kept occupied in his garden and his in his tool and his shed, and worked in his shed on his tools. He caught up with a couple of his church friends, and he was now isolating in the room that he shared with Elaine. He was refusing to come out, refusing to come for meals, and he was only going because Elaine was really making him go. So he felt very angry and betrayed with his son about what had happened. Elaine has a history of generalized anxiety disorder, which was never treated, and she always saw herself as being a warrior. She worried about Jim and his health in the new environment, obsessively worrying about it, preventing staff or assisting Jim with activities of daily living, and such as showering and personal care. She found that was too intrusive, having a staff member help out, and she needed a lot of reassurance from staff. Elaine was also experiencing early stages of dementia, which presented an additional barrier. So we'll come back to this couple a bit later on, but this kind of sets the scene for how things can go wrong from the onset. Where do psychologists come in, and what does the workload look like for a GP who's managing these two patients, for the facility, and everyone else involved? So what we know about well-being in late life is that, generally speaking, older people are doing well they're doing a lot better than younger generations. They're more resilient, that they have better coping mechanisms, and that only for those whose health and support network changes do we really start to experience this increase in decline in mental functioning. We know that if they have good protective factors, that their mental health will be retained. So their personal attributes, their physical health, their healthy behaviours, their physical activity levels play a huge importance, their social support and inclusion, as well as they are having a strong cultural identity and pride. So I often get asked, why are we exploring mental illnesses in residential aged care facilities? What's the point? I've been told quite a few times, fairly bluntly, but these people are going to die anyway. What is the point of delivering mental health services? And I think that's because often mental health is overlooked. We're not really recognizing for what it is. It is underdiagnosed. Often it's assumed that it's a personality trait. And importantly, it is treatable. I'm in my job because I actually see functional improvements in clients and their day-to-day activities, and it makes their stay in aged care facility a lot more pleasant for them, and that they actually make friendships, relationships, and they're able to enjoy that stage of their life much more than they anticipated to, or that anyone could foresee. So it's about improving the quality of lives of older people. So referrals are made when older person experiences difficulty adjusting to the environment, or if they are requiring counselling because of that adjustment. When the older person presents with symptoms of depression and anxiety, and they've meet the diagnosis. It can be one-off initial assessment the facility would make. A resident just moved into a facility and they want to do one-off assessment. Family can be requesting support for their loved one. The lady that I saw this morning, that was based on family's request to go and see her. And also if there's a critical incident that occurred inside the aged care facility. So there's quite a big range. But in the last couple of years, it's particularly been the first 2 points. The older person is experiencing difficulty adjusting, particularly with COVID, and the increased isolation experienced, as well as recognizing that depression and anxiety are present in the older person within the facility, and those concerns escalated to GPs and referrals being made to psychologists to come and visit on site. So what we know about depression in residential aged care facilities is that up to 1 in 2 residents present with symptoms of depression. Wendy shared with us earlier one of the slides about 49%, and that statistic tends to, wean in between. Initially, 7 years ago, they would say 26% of residents had depression, then it went to 49%. The latest one that I saw was 52%. So 1 in 2 residents presenting with symptoms of depression is fairly significant when you think about a facility of 160 residents or so. That's a really, really high concentration of mental illnesses. We know that depression is routinely screened using Cornell scale for depression and dementia. That is what the aged care facility does as part of their aged care funding instrument. So the residents often are screened when they come in, but over the years there's been quite limited implications for what does that high score actually mean. Are they escalating that to the GPs and saying, look, we want you to know that this person scored 20 in Cornell and they need to be reviewed by you in terms of their mental health? And unfortunately, quite often those assessments are just filed away, claimed an AG fee, and not revisited. So part of what I do with aged care facilities when I talk about education and training is how do we treat when someone has a score of 20 versus when someone has a score of 10 versus when someone has a score of 5, and when do we revisit that assessment? Because it's already being administered. We already have policies in place for it being administered. It's more so how do we put in clinical implications of that very important assessment tool, which tells us about a number of physical symptoms that the person might have when it comes to their mental health, such as changes in their sleep, physical symptoms, changes in their appetite, weight loss, and such. So what we know about depression in late life is that often it can be masked by other health conditions. It can be poorly detected. I know GPs are very time poor. By the time you attend to scripts and everything else that might be going on for the person and their physical health, it's very little time left to look at, the mental health aspect. It's poorly diagnosed, but it's treated. Older people are more comfortable reporting their pain and physical symptoms, which may in fact be depression. They're less likely to describe wording that suggests that they have depression. So they're much more comfortable to talk to you about those physical symptoms. It can be normalized as part of aging. It can be normalized as being in an aged care facility, that, it is normal to get depressed when you're in an aged care facility. It is normal to feel anxious. And older adults might not necessarily have a past history of depression in their earlier life. So they might have something called late onset depression. Anxiety, on the other hand, is far less researched. And it can be, quite situation dependent. What we often see in aged care settings is if the older person is experiencing anxiety, it is often the behaviors that get the attention of staff. So there might be, avoiding getting out of their room, avoiding standing up, avoiding going on the bus trips, avoiding, dining room, or they might be constantly seeking that reassurance from staff. And so that's often the trigger for why the referrals, being, requested from GPs. It's like, oh, this person, is agitated. They take a lot of time from staff. So often it's the residents who take a lot of staff's time that get that attention, as opposed to someone who might be isolated and lonely in their rooms because they're not as demanding on the staff and their time. Often people who have anxiety, like Elaine, have a past history of anxiety. And we know that if that is the case, that often before they have cognitive changes, before they move into aged care facilities, they can engage in pleasant activities which reduce their symptoms of anxiety. So if their procedural memory is not impaired, they can do things such as, making their favorite Christmas pudding, going for long drives, doing things that help them manage their anxiety. I have a client who's, very keen, she was very keen on exercising, and she always talks about her anxiety as something that she needs to get rid of. And she finds it very challenging inside an aged care facility to get enough exercise to help to manage her anxiety. So these are the little things that sometimes people have insight into their own mental health without recognizing it as a mental health condition and putting a label on it, but they recognize that that's how they cope. And once they're in an environment where they can't do it, or if their memory has changed and that the procedural steps of how to do things is impaired, then they're likely to feel more agitated. So we know that in aged care facilities, anxiety is not routinely screened. And as I mentioned earlier, it's far less researched than depression because the Cornell scale used is routinely administered. Geriatric anxiety inventory is not routinely administered. That's what I give people when I first start seeing someone who has anxiety pre and post treatment, but not routinely by all residents. And it's estimated that anxiety is a lot higher than depression. Anxiety is estimated to be higher in general population than depression as well. And we know that there's a high comorbidity between anxiety and depression, as anxiety can affect the outcome of treating depression and can increase the relapse. Similarly, we know that increased mortality, including by suicide, when anxiety and depression remain untreated in dementia, are very, very common as well. So just briefly, we're going to talk just to cover on suicide, is that men aged 85 plus remain at the highest risk of suicide. I have seen a number of people, older men and women who've moved into aged care facility because they attempted suicide. There are less warnings or explicit cues. There's less history of previous attempts. There's a greater prevalence of depression in context of physical illness, feelings of hopelessness, and older people are less likely to contact mental health services, particularly those who have attempted suicide and who have suicidal ideations. And this is part of what I also explored in my research, which I'll talk to you a little bit later on as well. So what we know in aged care facilities, when people are well protected, when they are in an environment where, you know, they're being cared for and they have, you know, staff who are keeping an eye on them, is that clients who are at risk of suicide tend to be more isolated and withdrawn. They will have suicidal ideation, but not physically be able to do it if their physical health has actually declined. And so often what it might present as is intentional self-neglect, where they choose not to eat and where they choose not to get out of bed, purely based on their physical, purely based on their mental health, not on their physical health. So I've, over the years, been referred quite a few clients who, you know, they said, look, we can't do anything, we can't get them out of bed. And unfortunately, if that client has decided at that stage that they don't want to do anything, and if they haven't eaten for, you know, 2 weeks, by that stage, it's very difficult to make psychological change, because they feel like that is one area or aspect of their life that they can control. So if we can help them before they get to that stage, it's so important, and the difference can really be made before they, you know, decide that no, you know, that's their way out. That's how they see the only way for them to escape the reality of what they're going through. We know that with comorbidities, older people are admitted to aged care, residential aged care, not because they're elderly, because of their declining health and having to meet the criteria for why they are in residential aged care. So I also know from my clinical experience is that those whose lives have changed overnight, who've had something happen overnight, they usually find it a lot more difficult to adapt to that environment than those who have had slow changes over a prolonged period of time, such as Alzheimer's disease, where it might take a bit of time, and it can be difficult for families to decide at what stage do they actually move their loved one into care. When is that risk of them being on their own in their home environment too high, and they need to be in a safe environment? And sometimes families find it really difficult to find that line. It's, you know, when do we actually move mum or dad in? And often it tends to happen around the fact that the family might be going on holiday, like Jim and Elaine's son. And so they realize that they can't keep doing and delivering the support that they need, and the home care package perhaps is not sufficient enough, and they move their loved one into care. But sometimes that can be a bit too late if they move someone into, you know, a low care facility where, you know, they have access to getting in and out, and then the older person tries to go back home. I've attended to quite a few of those instances as well. So we know that both physical health can impact mental health, as well as the impact of mental health on the physical health, and the bidirectional relationship that they have. So if, you know, I talk about my client who's had, you know, a stroke, how it's affecting her mental health and her well-being, not being able to physically do things or express herself verbally as well as she used to before, as well as how physical health can decline if someone has depression and they're not keeping active and they're not engaging as much in their community, and what's happening to their physical health and deconditioning. So what works with older people is same what works with younger people. Older people respond really well to cognitive behavioral therapy. It needs to be tweaked and adapted slightly for people who have sensory impairment. If they can't read, or if they can't write and complete the homework in between the sessions, how can we actually help them sustain the skill level? So often I have an exercise book that they have in between the sessions that they can refer to information, writing down notes. And we also know there's substantial evidence on the effectiveness of cognitive behavioral therapy in dementia as well. So if an older person has early stages of dementia, that they can respond well to CBT as well. Reminiscence and life review is another therapy that older people respond to well as well. But I know that through Medicare items, it needs to be evidence-based therapy. So cognitive behavioral therapy it's the most common type of therapy used with older people. It can be mixed with mindfulness activities or reminiscence or life review and incorporated into that. But generally speaking, most mental health professionals that I supervise and we see, they will do cognitive behavioral therapy. So just revisiting Jim and Elaine. So they've had individual sessions with 2 different clinicians, and looked at how Jim's goal was how to adapt to his new environment, identify enjoyable activities, form friendships, and improve relationship with his son. And for Elaine to support her adjustment to new environment, address her health anxiety, identify opportunities where she can meaningfully contribute. And so she was given task of, helping out in the laundry or setting up the table in the dining room. And so Jim had 10 sessions, and initially his geriatric depression scale was 25 out of 30, which was really high. And after the course of 10 sessions, first 6 were weekly and then fortnightly, that score dropped down to 12 out of 30. He was able to adapt better to his environment. He was more engaged. He was less isolated. He had more structure in his day. And similarly with Elaine, she had 12 sessions, and her pre-GI was 16 out of 20, which was really, really high, and then post 8 out of 20. So we have seen those clinical improvements in both of them. I've similarly this year, as part of COVID, been running wellness adventure groups across a number of different aged care homes. And we've seen, up to 16 people come together in a group. In some instances during lockdowns, that program was delivered individually in people's rooms as well. And pre and post measures also reduced the rates of depression and anxiety by 50%. So outcomes can improve and other people can respond well to interventions. The groups were not psychological interventions. It was more so about psychoeducation, socializing, giving them opportunities to connect with one another. So I know that Wendy also touched on the importance of collaboration. It's so important when it comes to maximizing client outcomes. All other health professionals who visit aged care facilities, and I have worked quite closely with OTs and physiotherapists and speech pathologists to get the best outcomes for my clients. It's to work to support client and their goals. I can't alone help them with their goals. So if it is about improving their physical tolerance and working on the anxiety because they might have fear of falling, working alongside a physiotherapist has helped the client achieve those goals, so that we work collaboratively on those things. Liaising with staff on site to support client with any tasks in between consultations is really helpful. So it's not just about what is discussed during therapy, during that 1 hour a week, 1 hour a fortnight. What about all the other times? What are they doing between the sessions? How do they implement the skills discussed during psychotherapy is even more important than what we actually do one-on-one. And this is why often when I do the session with the older person, I try to do it outside of the room. I try and get them, into the garden, into the outdoor space, into, part of the session, show me where you go for your meals, show me where you do your exercises, so that it's not just, the talk therapy of sitting down in the 4 walls and talking about, the grief and loss that they're going through, but more so about what can we do right here and right now to help them adjust to the environment. And also, the big clinical question is also about deciding and recognizing if and when is it appropriate to involve the families. And so, recognizing when family input is helpful, beneficial, because they know the residents so well, but when is it actually, about giving the older person their own sense of privacy and ability to engage with the therapist and not feel like after every session we need to report to the family and give them a rundown of how the session went. For some family members, they might be going through their own difficulty accepting that their loved one is in care, that they're not looking after them and themselves at home. So often it's also finding where family members can get their own support network as well. So we know that there are a number of strategies that can boost social connection and help older people in residential aged care. So regular contact with friends and loved ones has been really important. I help residents, to have phone calls, video calls with their loved ones, and staff can maintain it between the sessions, having a good support network. Keeping physically active is really important, and finding the reason why the older person needs to keep physically active. So it could be a functional, such as, encouraging them to help out with their own washing, and then they have timetables when they go to do their own laundry, and keep active from that, from that perspective, rather than just giving up and saying everything is being done for me. Practicing self-care strategies and actually finding out what they respond to the best. And if it is mindfulness, and if they have hearing impairment, what else can they do to be more mindful? Maybe it's about, sitting in nature, observing the environment. It could be about the affirmations. It could be meditation. It could be that the self-care strategies that they implement can be quite simple, but if they can do them on a regular basis, they can be done and sustain a lot more. So it's not just about, on the news seeing that an older lady has bungee jumped at the age of 96. It's what can we do week in and out to help maintain their sense of self-worth and their own self-esteem. The other ones is maintaining hobbies and interests. So often for a number of my clients, they might be knitting and then they can't maintain those fine motor skills. What can they do instead of that? What can we find that it's swapping rather than stopping? And how can we maintain their engagement and interest? Card making. I know there was a massive phase where everyone was doing colouring in. For some people that was trivial and simple, but for some it was really engaging. So finding activities that are of interest to them. And this is why staff training is really important as well, is meeting those social needs of residents. Long gone are the days where just having bingo on meets everyone's needs. Looking at how to engage music and art, so through music therapists, art therapists, as well as pet therapy, and even incorporating wildlife. I've got a lady who likes to sit out the back of a facility and watch magpies come in and interact with nature. So it doesn't need to be expensive, rare, and infrequent. There are many ways that can be done on a regular basis. I actually had a client who was non-verbal, but she was able to communicate even though she was nonverbal. And she pointed out to me one day that she was watching, swallows build a new nest. And so, for her, that was being able to articulate to me that that's what she was focusing on, and that's how she was practicing mindfulness, was so important to her. Okay, so I've only got a few more minutes, and I just wanted to very briefly touch on my research. Okay, so my research looked at emotional and psychological well-being in home care workforce outside of residential aged care settings. But I think it's really important because a lot of the topics that were brought up in this study applied to both settings. And it was about escalation of concerns for our clients' mental health and how that can be enhanced. So I did 4 studies. The first one was looking at, organizational factors for home care quality study. Then we looked at mental illness in clients. And then I looked at this concept called emotional contagion. So I did both qualitative and quantitative studies. And the quantitative study was just to further enhance what we looked at in terms of emotional contagion. So emotional contagion is a term called where we, automatically catch emotions from one another. And it applies, in all sorts of settings. And whilst catching positive emotions has been positive because it can improve the mood, if you're interacting with a positive person, if you have a client who comes and sees you and they're happy, you're likely at the end of that consult to feel warm and fuzzy and happy and in a good mood. But it was more so about looking at the impact of negative emotions and what happens when clients are in a bad mood. And how does that affect us and our own well-being in terms of them projecting that negative emotion on us? So what I found in my study was that although positive interactions led to better service delivery, exchange of negative emotions impacted workers' own well-being to the point that they were asking not to be sent back to see those clients again. It was affecting their job satisfaction and intention to stay. And just going back to those statistics that both Wendy and I shared earlier about the prevalence of mental health conditions in residential aged care settings, just got to think about, for staff, coming on site and experiencing such so many negative emotions from the residents on a regular basis, what impact it has on them, and also on their own, motivation to get stuff done. I know when we ran those groups and with individual services and helping out Elaine and Jim, how it was so positive for staff to be able to meaningfully participate to something that improved the well-being of those clients. And I think that, screening mental health of clients, escalating concerns to GPs, attending to those mental health plans, not only improves the quality of the life of the older person, but it creates a better level of care and better service delivery in the entire aged care facility. If the residents are in a good mood, and if they are engaged, and if they're not isolated, and if they're meaningfully engaged, it's a better experience for everyone. So that is all that I had for my presentation. And now I'll pass it back to Mari.
Thanks. That was fantastic, both Wendy and Julie. Great presentations. We actually don't really have many questions on Slido, but I guess I have a couple that I'd like to ask, if that's okay, and I guess a couple of comments that I'd like to make. Firstly, I would have to claim complete ignorance that a lot of these mental health items existed prior to the last 12 hours. So that's new information for me, which I guess is concerning, considering these item numbers have existed for at least 12 months now, and they're potentially going to disappear in 6 months. So I guess, we really need to be out there advertising that we can access these services. So quickly, a couple of questions. The first one is from Wendy. For Wendy, if that's okay. Can GPs refer to multiple providers from one mental health care plan, or do we need to do a chronic disease care plan as well? So you were talking about the fact that we could refer to a psychologist and an OT. Is that on the same mental health care plan, or do they have to be on separate ones?
Marie, I'm glad you asked that. So the benefit of this, what's available, is we actually have two different areas we can refer to. So we have the mental health component for the psychologist or for the OT, but we also have the allied health initiative, which is giving an additional 10 services. So we can certainly incorporate a mental health plan and a management plan to ensure that that resident gets as much provision of service as possible. So the mental health plan could be, you could definitely refer an OT and a psychologist under that plan. But when you have the ability to do the allied health plan as well, why not make the most and give that resident as much opportunity as we can?
Okay, so basically you're suggesting that we do both a mental health care plan and a chronic disease care plan and team care arrangement. Yeah.
So that gives them 30 services.
Yeah. No, that'd be heaps of sessions for sure. Like another question. Sorry, I had lots of questions about that, if that's okay. So as far as the mental health care plan review, so you have 6 sessions, you do a review, you get another 4. What's the next item that you bill to get those extra 10 sessions? I was a bit unclear about that.
Yeah, so that would be depending where you see them. So if you're seeing the resident in the aged care facility, Marie, the initial item number that you would charge is your plan and then your review. It would purely just be a consultation to review, unless it had been an additional 3 or 4 months when you could bill the second review. But as a rule, the plan, then the review, and then just a standard consult to generate the rest of those, because Medicare are already recognising that you want those 20 sessions because you've generated the original item numbers.
Okay, so basically the mental health care plan, then the review, and then the normal consult item number, or if it's more than 3 months, you can do a second review. Is that correct?
Correct. That's right.
Okay. Okie doke. A couple of questions for Julie. Again, they're all from me. Sorry.
That's okay. I just think it's also important to highlight, just about talking about the mental health care plan. The Australian Psychological Society has actually informed us that As of this year, we actually need to have in the referral from the GP specification how many sessions the client is being referred for, and we are being audited for that as well. So it's really important for GPs to specify how many sessions they recommend for the person, as opposed to just keeping the referral open. And sometimes I know it's hard to know initially how many sessions, but if it's initially for the 4 sessions and then asking for a review, or 6 sessions, really specifying that. It's a requirement, and it's also helpful for the mental health professionals as well.
I must admit, I know what I'm doing, and I presume it's okay, is I'm actually saying in the referral that I want the maximum 20 sessions as per COVID rules, and I'm putting that on everybody. And it seems to me that covers everything then.
Yeah. As long as it is specified. So, there is no issue with too many psychologists going to aged care homes and delivering services. There's only very few of us, as I'm sure Charles can tell you. So it's not an issue from that perspective. But now I think Medicare is more so saying, just to make sure that, that the GP specified a number of sessions if possible.
Well, that's a brilliant segue into the next question. Which is, are psychologists and mental health practitioners keen to attend residential aged care facilities? I know personally I've had great difficulty getting mental health care workers to provide a service to people in residential aged care facilities. It's been quite difficult.
It has been, and as supervising other psychologists, I've heard both sides of the story. I've had very keen psychologists go to aged care sites, and GPs have been told, no, we're too busy doing COVID vaccines, come back. One has been told not to come back till February next year because he's too busy to do referrals. So I know that everyone's under pressure, and if we don't have those referrals, we can't actually go on site and deliver services. So that makes it really difficult to attend to that. I started off by having one referral in one facility, and then it's really helpful for the GPs if they are attending to, to also keep in mind if there are a couple of other clients that would benefit from the service, so that this mental health practitioner is going there on site perhaps for half a day, for 2 or 3 visits, as opposed to going to see Bob in this facility, Jane in this facility, Elaine here, Jim there, so that they can sort of structure their day in a sense, by being given a couple of clients to see. I know that Wendy covered about the flag fall, applying for one client, but many clinicians are finding that they're just on the road seeing, they just kind of across different facilities, as opposed to having few facilities where those Cornell scores are high, where GPs are notified and they've got a system in place. The facility that I go to in Newcastle, I've been working with them for 10 years. And so it's taken a lot of time to actually fine tune the system. And it comes to, having regular GPs who know the work, for facility, also recognizing what's the processes, what needs to happen. It's not just about writing on a piece of paper, yes, refer to psychology, actually doing the mental health care plan and streamlining the processes. So it really needs that multidisciplinary approach. Keen mental health professionals and GPs who recognize that the client is at risk or experiencing a mental health condition.
And perhaps some input from the residential aged care facility as well to identify those people for the GPs.
Yes.
Because realistically, we're only seeing the people, the residents, as a snapshot in time, probably, anywhere from weekly to every 3 months, depending on the service provided. So I think it's important that the residential aged care facilities who see the people every day make that recommendation. And often that's just the little prod that we need to undertake that process. I would also imagine that if you show that you've been providing a service in a residential aged care facilities, other GPs will notice that and then think, there is somebody that we can refer to.
Yeah, absolutely. Making yourself known and sharing that information on site as well, so that they can let other GPs know as well.
Okay. So there are still no further questions. So if you don't mind, I have a couple more, if that's okay. So in your experiences, how has, and this is for both of you, I guess, how successful has telehealth been in residential aged care facilities, particularly from a mental health consultation perspective. Personally, I've found that telehealth consultations in residential aged care facilities are, I mean, they're always challenging, but they're probably more challenging than face-to-face. Obviously, keeping people in the same place. Obviously, people have difficulty with vision. They have difficulty with hearing. They don't understand the technology. I've not found it an ideal medium, I would have to say.
Look, Swinburne University rolled out telehealth clinic quite some years ago for residents of aged care facilities, whereby they have postgraduate psychology students who are delivering services. So any aged care facility resident can self-refer without the mental health care plan. There's no need for GP referral, and I still know that intake has been very, very slow on that. I have personally found during, the pandemic, not being able to visit facilities difficult. When I did make those phone calls to clients who have known me for, a long time, that those phone calls were not treatment, that they were more of a social catch-up, that they couldn't really recognize the purpose, and that phone call was replacing the visit. And it's been very challenging. So this was, Murray, with clients who do not have hearing impairment or cognitive impairment. So they were the ones that I thought that would respond well to that, and they didn't. So it was even less successful for the ones who had sensory impairment and cognitive changes.
And that's certainly been my experience as well. But it's in certain periods of time, it's what we have, and it certainly, if it increases access, then that's probably a good thing.
Yes, and so this is, during that time, this is when I actually worked with facilities and got them involved in doing activities with the residents to get them out of the room. So I didn't replicate psychotherapy, but just increased that socialization with my guidance.
Okay, all right. Well, look, thank you, ladies. I think we've probably exhausted the questions. So, Charles, I might hand back to you, if that's okay.
Thank you so much, Marie. Really appreciate you facilitating tonight's event. And of course, a big thank you to Wendy and Julie for preparing your content and presenting this evening. That was fantastic. I learned a lot myself. Of course, thank you to you, our audience, for taking time out of your day and spending it with us. Just a reminder that the session tonight is being recorded, and the recording and the slides will become available from tomorrow in our PHN Education Library on our website. So if you have any colleagues that may be interested and missed it, they can definitely catch up and watch that in our Education Library. You'll see in the polls tab of Slido, the evaluation survey is now live. If you would like a certificate of attendance for this evening, please fill that out for us. But of course, the survey gives us your very valued feedback. We're always looking to how we can improve, how we deliver education to you. But it's also an opportunity for you to let us know what topics you're interested in, which helps us to guide our content and our speakers. So that's all from me. Would love you to fill out that survey before you log off, but I'll keep it open for the next day or so if you do need to rush off. But really appreciate your input for these series. And I also just want to mention to Wendy, particularly, who's been with us for each session. It's been really valuable and enjoyable working with you. So so thanks everyone. We hope you enjoy the rest of your evening. Good night.